Good evening. My name is Beth Phillips. I'm a consultant haematologist practicing at the Christie Hospital in Manchester. And it's a pleasure to be with you this evening talking about the frontline management of classical Hodgkin lymphoma. This is an area where we're very fortunate to have a plethora of randomized phase 3 trials producing a very high level of evidence with which to guide our clinical practice. However, each of these trials has now given us multiple different treatment options, all with very good outcomes. And therefore selecting the right treatment for the right patient has become increasingly more complex. Therefore, over the next 35 minutes, I will try to guide you through some of the risks and benefits behind the different treatment pathways and discuss the evidence in the 3 key risk groups in adult Hodgkin lymphoma. We're not there yet, but one of the major advances and the major changes coming over the next few years is likely to be the introduction of targeted agents, and I will discuss a bit about their current role and the current evidence after that. And then finally, I will highlight some of the management strategies for older and comorbid patients, an area where unfortunately the level of evidence to guide practice is much lower. But first, I'll take you through some of the main principles behind Hodgkin lymphoma treatment and some definitions. When we talk about early stage and advanced stage disease, we're usually referring to Ann Arbor stage 1 to 2 and stage 3 to 4 respectively. However, the lines are a little blurred. Most European protocols include patients with stage 2B disease who have high-risk features, including extranodal disease or a bulky mediastinum in advanced stage protocols. Furthermore, most systems include a third intermediate risk group who have separate treatment protocols. In adult Hodgkin lymphoma, this is largely consists of patients with stage 1 to 2 disease who have specific additional risk factors, and it's largely described by the patient-unfriendly term early stage unfavourable. But for that reason, I will refer to it as intermediate stage throughout this presentation. And this intermediate risk group is variably defined by either EORTC or German Hodgkin Study Group criteria, which are very similar, but there are certain differences, particularly pertaining to age and the presence of extranodal disease. As if any one of these risk factors are present, the patient is deemed to have intermediate risk disease. For advanced stage Hodgkin lymphoma, the most commonly used prognostic tool is the Hassan-Cleaver score, also known as the IPS or International Prognostic Score. It consists of 7 variables, and if 3 or 4 of these are present, patients are generally defined as having high-risk disease. But importantly, this hasn't been used to risk stratify patients to different treatment pathways in clinical trials. But by far and above the strongest prognostic factor in Hodgkin lymphoma is that of early PET response to treatment. Shown here is a graph of one of the early studies of interim PET, where patients with advanced stage Hodgkin lymphoma received 6 cycles of ABVD and underwent PET assessment after 2 cycles, which did not alter their treatment. And you can see that patients who are PET negative after 2 cycles of treatment had excellent outcomes with ABVD alone, whereas patients who are PET positive at that stage had very poor outcomes indeed. And this has led to the advent of PET adaptive treatments. The big question is, can we reduce treatment burden and minimize toxicity for this favorable risk PET negative group? And for the PET positive patients, can we explore more intensive or novel treatment options with the aim of improving survival outcomes? In terms of frontline chemotherapy regimens, ABVD has been in widespread use since the 1980s and is still one of the most commonly used chemotherapy regimens worldwide today. Grade 3 to 4 neutropenia is extremely common, and the bar chart here shows rates of neutropenia for patients with asymptomatic neutropenia who continued treatment without dose delays and without GCSF. And with this treatment schedule, febrile neutropenia is extremely uncommon, but dose intensity was preserved, which is important for maintaining outcomes. The other regimen that is commonly used is escalated BIRCOP. This is a more intensive outpatient regimen consisting of 7 drugs. It is more intensive, and therefore febrile neutropenia is more common, and therefore GCSF as well as antimicrobial prophylaxis are mandatory. In the UK, we more commonly use a variant of escalated BIRCOP DAC. This substitutes procarbazine for dacarbazine, and this is extrapolating from data in paediatric studies. which showed that substituting procarbazine for dacarbazine leads to much more favourable levels of FSH, likely to preserve fertility better. We also know that it has less hematologic toxicity and can reduce the rate of transfusions by approximately half. Also intriguingly, there are data showing that patients who received escalated Beer-Koptak have a lower mutational burden within their hematopoietic stem cells than patients treated with escalated Beer-Kop. Whether this translates to a reduction in secondary malignancies is not yet clear. For all these reasons, we commonly make the substitution in the UK and deliver escalated Beer-Koptak. And this is based on a large retrospective series now showing that outcomes are very good indeed, similar to those published with escalated Beer-Kop. But because this is based on real-world data and not clinical trials, this switch has not necessarily been made worldwide. So coming on to the main treatment groups, early-stage Hodgkin lymphoma has evolved from treatment with radiotherapy alone in the 1950s and 60s to recognition that combined treatment with chemotherapy and radiotherapy led to improved outcomes. With modern treatment approaches, we can now achieve 5-year survival rates that are well in excess of 97%. And whilst this is a real success, there's been increasing recognition that patients are much more likely to die from non-Hodgkin causes, in particular secondary cancers and cardiovascular toxicity as a result of the chemotherapy and radiotherapy regimens used. So there's been a real focus on minimising late effects in this treatment group and trying to identify the minimum effective treatment required. With improved staging, treatment has naturally evolved to give smaller radiotherapy fields and smaller radiotherapy doses. And one key trial was the HD10 trial, which showed 2 ABVD was as effective as 4 ABVD, and 20 grade radiotherapy was as effective as 30 grade in this patient group. Going forwards, the key questions are, can we give even less chemotherapy? And can we omit radiotherapy entirely? One useful trial is the HD13 trial. In this trial, patients received 2 cycles of chemotherapy plus radiotherapy, and patients were randomized for omission of either bleomycin or dacarbazine or both from standard ABVD. And what this trial showed was that there was some loss of efficacy if either drug was omitted, and therefore ABVD very much remains standard of care. However, it's important to note that omitting bleomycin alone, the green line on this graph, led to a very small decrease in efficacy, equivalent to about just under 4% at 5 years. And therefore, in patients with significant risk of bleomycin lung toxicity, those with significant respiratory disease or older patients, the benefits of omitting bleomycin may outweigh the risks. And there have been a series of randomized phase 3 trials looking at whether radiotherapy can be omitted. Slightly different design, but all asking the same question. If patients are PET negative, is it safe to omit radiotherapy? These trials differed slightly in their inclusion criteria, in the number of ABVD cycles delivered, and in the timing of their decision-making PET. But the definition of PET negativity was the same in all 3, broadly equivalent to a Deauville score of 1 to 2. The first report was a UK rapid trial, which showed a 3.8% difference in PFS in favour of combined modality therapy. It didn't meet non-inferiority criteria, but the authors concluded that this small difference in PFS was likely to be outweighed by late toxicity 20 to 30 years in the future, and concluded that it was reasonable to omit radiotherapy in PET-negative patients. The other 2 trials came to different conclusions. There was a 12% difference in PFS in the H10 trial and a 7% difference in the HD16 trial in favour of giving radiotherapy. And both of these trials concluded that radiotherapy remains standard of care. Although it's important to note that overall survival is very high across all 3 trials, and considering the risk of late toxicity in selected patients, omitting radiotherapy may be reasonable in selected cases, particularly where the risk of radiation toxicity is high. What about PET-positive patients? It's important to note this is a minority of favourable risk patients, less than 10%. The H10 trial suggested that there might be a benefit for intensifying chemotherapy to escalated Beer-Kop in these patients. But this part of the trial also included intermediate risk patients. Very few favourable risk patients were included. in HD16, and rapid patients received ABVD alone plus radiotherapy. And outcomes were very good, apart from one particular group. Patients with Doble score 4 did extremely well with chemoradiotherapy. Patients with a Doble score of 5 had clearly inferior outcomes. And this is a pattern that is repeated across all 3 risk groups. Patients with a Doble score of 5 on early PET assessment have worse outcomes, and the standard of care for this patient group is yet to be defined. So we now have multiple different treatment pathways, but if we're looking to minimise treatment burden, 2 stand out. Firstly, the HD16 approach, where the risk of radiation toxicity is low, 2 ABVD plus 20 gray radiotherapy for all. But if the risks of radiotherapy are a concern, particularly young patients with mediastinal disease, then the rapid approach is also reasonable. 3 ABVD and no further treatment if PET negative. So I tend to give 2 ABVD followed by PET assessment and give radiotherapy or 1 further cycle of ABVD, depending on the individualised risk of radiotherapy, considering age, gender, disease location. Radiotherapy is routinely given to PET positive patients. Another consideration is disease risk. We know that a higher baseline tumour diameter increases the risk of relapse in this patient group. And this is tumour diameters of around 5 centimetres or above. So these are patients who the benefits of radiotherapy may be higher. It's also unclear we can admit radiotherapy in patients with a Doble score of 3. And the standard of care has now involved site radiotherapy as per international guidelines. And for patients under the age of 25 years in the UK, proton beam therapy is available for selected patients. So moving on to intermediate stage Hodgkin lymphoma, the standard of care in the pre-PET era was 4 ABVD followed by 30 gray radiotherapy. But there was a widespread recognition that sometimes the radiotherapy fields were too large in this group, and therefore many were treated on advanced stage Hodgkin lymphoma protocols that usually incorporate less radiotherapy. So a couple of controversies here. The first is whether ABVD is sufficient. The relapse risk is higher in this group. The German Hodgkin study group devised a 2+2 regimen. That's 2 escalated BIRCOP followed by 2 ABVD. And they assessed this in the HD14 trial, directly compared with ABVD alone, followed by radiotherapy in both arms. And there was a clear PFS advantage for the 2+2 regimen. That's 7% difference in freedom from treatment failure at 5 years. And this was adopted by the German group as their standard of care, but not internationally. Firstly, because of the increased toxicity of this regimen, and secondly, for the lack of an overall survival advantage. Other controversy is whether radiotherapy can be omitted to minimise late toxicity in this group, who often have wider radiotherapy fields. So one of the 2 trials looking at this was the HD17 trial. This used the 2+2 chemotherapy backbone, and patients who were PET negative after chemotherapy were randomised to 2 different strategies. One where they'd received 30 gray radiotherapy as standard of care, the other where they received no further treatments. And the graph here shows outcomes for PET negative patients. There was a 1.7% difference in progression-free survival at 5 years, which met their pre-specified non-inferiority criteria, and they concluded that radiotherapy can be safely omitted in PET negative patients after 2+2 chemotherapy. Although note a conservative definition of PET negativity, and a third of patients were PET positive in this trial. The other trial was the H10 trial, which also had a separate arm for intermediate risk patients, and this used the ABVD backbone. Patients were randomised either to receive 4 cycles of ABVD plus radiotherapy if PET negative, or 6 cycles of ABVD alone. The results of this trial were less clear-cut. There were more early relapses in the chemotherapy alone arm, and therefore the trial's randomisation stopped early due to futility. But we can see that that curve then plateaus. And the difference in PFS at 5 years was only 2.5% in favour of combined with that modality therapy, which, considering the risk of late toxicity in this patient group, is minimal. And therefore, even though they didn't meet their own non-inferiority criteria, I do believe these results support omission of radiotherapy in PET negative patients following ABVD, 2 cycles of ABVD chemotherapy. What about the PET positive patients? So the patients were randomised either to continue with ABVD or to switch to 2 escalated BIRCOP, followed by radiotherapy in both arms. And at 5 years, there was a very clear PFS advantage in favour of escalated BIRCOP no significant overall survival advantage, but this was widely adopted as standard of care. It's important to note that at 10 years, the recent results have been released, and there is a smaller difference in progression-free survival, which is no longer statistically significant. Nevertheless, this approach is still widely used. So how to put this together? Frontline ABVD or a 2+2 approach are both very reasonable options. For PET-negative patients, the role of radiotherapy is unclear. I only consider it in very selective patients, that is, those who are treated with ABVD, who have a single dominant site of disease, which can be safely irradiated with a low risk of toxicity. But for the majority of patients, I do not give radiotherapy. But overall survival is very high with all treatment approaches. I tend to start with ABVD, and if they're PET negative, I give 6 cycles of chemotherapy, and if they're PET positive, I tend to give escalated BIACOP, either 2 cycles followed by radiotherapy as per H10, or 4 cycles of escalated BIACOP as in advanced stage Hodgkin lymphoma protocols such as RAPL. But I know a lot of colleagues in some centres around the UK have switched to a 2+2 approach, particularly given the more confident conclusions about omitting radiotherapy in PET negative patients. Moving on to advanced stage Hodgkin lymphoma, the eternal debate has been between frontline ABVD or more intensive BIACOP-based therapy. There have been multiple randomised trials, most of which show a progression-free survival advantage for BIACOP, none of which have individually shown an overall survival advantage, although this meta-analysis released in 2020 suggests a small PFS difference in favour of BIACOP, 2.4%. However, there is more toxicity. A secondary AML in MDS incidence about 2% with BIACOP. Infertility and early menopause are frequent, and particularly a concern for younger males is a risk of symptomatic AVN or osteonecrosis. Of course, more acute toxicity, febrile neutropenia and transfusion. So moving on from this, the question is, can we improve outcomes or reduce toxicity by using PET-adapted treatments or by use of targeted agents? For those using ABVD first approach, the RAPL trial is one of the key studies looking at PET-adapted treatments. There are 2 aims. The first aim is looking at reducing treatment burden for PET-negative patients. Patients who, with a negative scan after 2 ABVD, were randomised to either continue with ABVD or switch to AVD omitting bleomycin. And you can see from the curves on the right, there was no difference in progression-free survival, but less toxicity when bleomycin was omitted. And this was widely adopted as standard of care. For the PET-positive patients, this was not randomised, but patients were switched to BIACOP-based therapy. And the 3-year progression-free survival rate of 67.5% was much higher than reported in historic controls. And therefore, this was also widely adopted as a standard of care. And by using this approach, you only expose a minority, 16%, to the toxicity of BIACOP. Other trials have looked at improving escalated BIACOP therapy, in particular trying to de-escalate therapy for PET-negative patients and reduce toxicity. One such trial is the HD18 trial. Patients who are PET-negative were randomised either to receive a total of 6 to 8 cycles of escalated BIACOP as standard of care, or to reduce the amount of treatment to 4 cycles of escalated BIACOP in total. And as you can see from the curves, there was no difference in progression-free survival. And therefore, patients who are PET negative routinely receive 4 cycles of escalated BIACOP as another standard of care. But note, a conservative definition of PET negativity, only just over half of patients were de-escalated on this trial. Another way of reducing toxicity of escalated BIACOP was assessed in the AHL 2011 trial. PET negative patients were randomised to either receive 6 cycles of escalated BIACOP or 2 cycles of escalated BIACOP followed by 4 ABVD. And essentially, again, you can see there's no difference in progression-free survival rates between the 2 arms, but there was much lower toxicity in the ABVD arm, both in terms of acute toxicity, but also a marked improvement in all fertility parameters. So how to put these data together? Well, it's important to note the inclusion criteria difference. RAPL included intermediate risk patients. About 40% of patients had stage 2 disease. But it also included older patients. Just under 10% were over the age of 60, whereas others, BIACOP-based protocols are strictly for the under 60s. The PET Positivity threshold was very different between the three trials, and therefore the proportion of patients being PET positive was also very different. And there's also a marked difference in the duration of treatment for PET negative patients. In PET negative patients on HD18, 4 cycles of escalated BIRCOP gives a total treatment duration of just 12 weeks. But what about the outcomes? Well, recently the seven-year long-term follow-up data from the RATHLE trial been released. And although outcomes are reasonable, there's certainly room for improvement. Progression-free survival for the whole cohort was 78.2%, overall survival 91.6%. And there is still a gap between BIRCOP-based approaches. Whereas, as you can see, progression-free survival and overall survival rates on HD18 and AHL 2011 were both very high. So which treatment approach to use? I think, particularly with the long-term RATHLE follow-up data, I think there's an increasing recognition that stage 3-4 patients are likely to do better on escalated BIRCOP as long as they're fit and non-comorbid. However, there are still some patients that are appropriate for an ABVD RATHLE treatment approach, particularly those who are extremely concerned about fertility and are willing to accept a difference in progression-free survival rates. Also, potentially patients with very low risk of relapse and low IPS score, and particularly those who are older or have comorbidities. But the majority of stage 3-4 patients are likely to go on escalated BIRCOP-based approaches. I tend to start patients on escalated BIRCOP, and then they tend to be very clear on whether they wish to continue it or not. I start discussions very early, and if they're PET negative, I give them a choice between continuing escalated BIRCOP as per HD18 or switching to ABVD, considering toxicity and fertility concerns. And it's about 50-50 on the two different treatment approaches. So what about the introduction of novel agents? So the first randomized phase 3 trial to report was the Echelon 1 trial, which took patients with stage 3 and 4 Hodgkin lymphoma and compared 6 cycles of ABVD versus 6 cycles of brentuximab plus ABVD. And there was a progression-free survival advantage in favour of brentuximab ABD of around 7 to 8% at 6 years, but importantly also an overall survival advantage of 4.5%. And this is one of the very few trials in Hodgkin lymphoma to show an overall survival advantage. But it was not PET adapted, and therefore perhaps the standard arm received more bleomycin might be necessary. There was significant neuropathy with this approach, although obviously less lung toxicity. And in patients who we're most concerned about bleomycin toxicity, the older patients, it's not clear whether there's an advantage for brentuximab ABD over ABVD. There have been a number of subgroup analyses, a couple of which suggest an advantage for brentuximab ABD, particularly in higher risk patients. And on the basis of that, brentuximab ABD is licensed for stage 4 Hodgkin lymphoma in Europe and the UK, but it's not currently funded in the UK. More recently, the SWOG 1826 trial has reported looking at the role of checkpoint inhibitors in frontline treatment. This was in the plenary session at both ASCO and Lugano. This took patients stage 3 and 4 Hodgkin lymphoma. Significantly also included pediatric and adult patients all across the age spectrum with no upper age limit and patients with HIV. It compared 6 cycles of nivolumab plus ABD versus 6 cycles of brentuximab ABD. And an early interim analysis has been released showing significant progression-free survival advantage in favour of nivolumab ABD, 94% PFS at 1 year compared with 86% with brentuximab. They also showed lower rates of hematologic and neurologic toxicity, and much lower rates of immune-related toxicity than we see with checkpoint inhibitors as a single agent in relapse disease, 7% incidence of hypothyroidism, for example. But median follow-up is very short. This has the potential to change standard of care, but only if this PFS advantage is maintained for a few more years to come. We've also looked to novel agents to refine standard BIRCOP-based therapy. The BRICAD regimen substitutes brentuximab for bleomycin and vincristine. It also substitutes dacarbazine for procarbazine, and the steroid dose is changed to a shorter course of dexamethasone. The HD21 trial directly compared escalated BIRCOP versus BRICAD in stage 3 to 4 Hodgkin lymphoma or stage 2B high risk. It's PET adapted, so 4 to 6 cycles of treatment, depending on interim PET response. And the first endpoint was looking at treatment-related morbidity, looking at BRCAD to try and reduce the toxicity associated with BRCA. And they successfully showed that it could do this with a reduction in TRMB or treatment-related morbidity. But it didn't reduce a non-hematologic toxicity, so infections and things were similar between arms. This was mostly based on a reduction in hematologic toxicity. As you can see, a markedly reduced need for red cell and platelet transfusions. To be critical, this is similar to what we see with escalated BRCA, substituting procarbazine for dacarbazine. The differences in FSH will also mirror what we see with the likely effect of substituting procarbazine for dacarbazine. But they also did show a lower risk of neuropathy grade 2 to 3, which is likely to be due to brentuximab rather than vincristine. The second part was looking at non-inferiority of BRCA for progression-free survival. And in fact, the 3-year progression-free survival rates recently reported showed 94.9% PFS for BRCA compared with 92.3% for escalated BRCA. So certainly not inferior to BRCA. Not clear yet whether this regimen is superior in terms of progression-free survival. Longer follow-up is needed. So a highly effective regimen. What about the role of novel agents in early and intermediate stage Hodgkin lymphoma? Clinical trials are in an early stage of development, and phase 3 trials are only now underway. The RADAR clinical trial is comparing brentuximab AVD versus ABVD in early stage Hodgkin lymphoma in a radiotherapy-light rapid style approach. This is now open in the UK and several countries internationally, and is worth considering if you have a patient with early stage Hodgkin lymphoma. But further data are needed to establish the role of novel agents in other risk groups. Finally, coming to older and comorbid patients. We know these patients experience greater toxicity with chemotherapy. Treatment-related mortality is 5 to 10% after ABVD, and rates of lung toxicity are significant in the over 60s. We also know that over 60s do not tolerate escalated BRCA or other BRCA-based therapies, with a 21% mortality in the HD9LD trial. But conversely, there's much less concern about late toxicity with radiotherapy, and it tends to be used more liberally in this age group. We know that radiotherapy alone can be curative in about 2/3 of patients with early stage Hodgkin lymphoma. But treatment of advanced stage disease in older patients is more difficult. For fit patients, the RAPL approach is reasonable, but it's not possible to escalate treatment usually in the PET-positive patients. There's also a small trial that assessed attenuated ABVD, just 3 cycles for PET-negative patients, although this trial included very few advanced stage Hodgkin lymphoma patients. Quite commonly, I use the AVD regimen, certainly in patients in their late 60s and 70s, omitting bleomycin entirely. And there are some registry data from Sweden that suggest that AVD has better outcomes than CHOP in advanced stage Hodgkin lymphoma patients, but the level of evidence is generally low. The ACOP regimen has recently been devised and reported on by the team in Glasgow. It treated just over 40 patients with a median age of 74 with this regimen modified from BRCA, and showed very good progression-free survival rates, although numbers so far are reasonably small. What about novel agents? Well, brentuximab plus AVD is not available, but may be a reasonable option for some. The echelon 1 approach would only be appropriate for fit older patients. There are some data on sequential brentuximab, followed by AVD, followed by brentuximab maintenance. And outcomes in this single-arm phase 2 trial were very good. As I say, this approach is not available in the UK. And then finally, what if patients are not fit for anthracycline or bleomycin? Only real treatment option is Clivert. But progression-free survival rates with Clivert are less than 20% for over 50s with advanced stage disease. And therefore, this approach is best looked at as palliative at best. So to conclude, there are now several treatment options for most patients. Wherever possible, it's important to involve your patient in the decision-making process. There remain unmet needs. We need a high level of evidence to base our treatments for older patients, And we need more information about high-risk PET findings, the patient with Doble score 5. Reducing treatment-related morbidity is a key priority across all patient groups. And the question is, what is the role of targeted agents in frontline treatment? Can they improve survival rates and can they reduce toxicity? I suspect the standard of care in advanced stage Hodgkin lymphoma will change over the coming years. And also, can we identify better biomarkers for risk-adapted treatment above PET alone? Circulating tumour DNA has emerged as one of the most promising biomarkers and is now being evaluated within clinical trials. And then finally, I'd like to leave you with a reference to the very recently published BSH guidelines, which discuss many of these treatment options in more details. Thank you very much.
Hello, I'm Professor Graham Collins, and I'm delighted to speak on one of my favourite topics, which is the management of relapsed and refractory classical Hodgkin lymphoma. You will have heard a fantastic overview of the first-line treatment. These are my disclosures, by the way. And these are the learning objectives. So I hope that we can understand the problem, think about the aim of first relapse chemo, which is a complete metabolic response, talk about the best induction therapy, possibly as well second-line induction therapy if needed, the role of targeted treatments, particularly brentuximab and PD-1 inhibitors before autograft, the role of autograft, and then the role of targeted therapies after autograft, a little bit about allogeneic stem cell transplant, and then thinking about a very important group, which is relapsed Hodgkin lymphoma in older patients. So first of all, is relapsed Hodgkin lymphoma a problem? After all, we cure the majority of patients up front. So I put down here some of the survival curves from the RATTLE study. These are these first two curves on the top left. The first curve there is for patients who are interim PET negative, and the second curve for those who are interim PET positive. And I've also put the progression-free survival curves from the HD18 trial, showing a higher cure rate, but still around 10% relapsing at 5 years. So overall, if you think that there are different approaches used for different patients, roughly 2,000 new diagnoses of classical Hodgkin lymphoma a year, so around 200 to 250 relapses per year. So not that high numbers, but often patients are young and fit, and we need to, well, as we need to with every patient with lymphoma, offer them the optimum treatment for their disease. And actually, the rarer it gets, of course, the less experience we have with something. So it makes sort of educational talks like this perhaps even more important, so that we are up to speed with the latest developments. So let me base this around a case. This is a 22-year-old tree surgeon, real case, had 3-month history of drenching night sweats, pruritus and fatigue, a neck lump, blood tests that were quite inflammatory, so a mild anemia, raised white count, raised platelet count, slightly low albumin, biopsy showing classical Hodgkin lymphoma, HIV negative, and this was the PET scan. And you can see on the PET scan some particularly mediastinal nodes. You can see liver involvement, really quite dramatic splenic involvement, and also involvement of the bone. So this was stage 4 disease. International prognostic score was 5. And in terms of frontline treatment, well, you have heard the talk, there are many to choose from, and you can sort of take your pick. However, this patient who was treated actually initially in a different center from ours had ABVD 2 cycles. The interim PET showed a good response, but you can see in the mediastinum there is still some uptake. So this was reported as a Deauville 5 partial remission. Normally, the center that was treating him would have escalated to escalated BCOP-DAC, but actually the patient elected to continue with ABVD, and their end of treatment PET scan showed progressive disease, and he had a rebiopsy that confirmed this was active classical Hodgkin lymphoma. So 3 questions. What's the risk for this patient? What's the optimum line of next treatment? And what's the aim of the next line of treatment? Now, just before we move on to those questions, I just want to introduce you to this timeline. This is the sort of possible journey a Hodgkin patient can travel at relapse. It's, I guess, a worst case scenario in that they relapse multiple times. And this is for a sort of younger, fitter patient. So they start off on the left with their diagnosis, they have frontline treatment, they relapse. They then get first line relapse treatment. Now I'm going to avoid the term salvage treatment because patients hate that term. And I think just relapse treatment is fine. So first line relapse, and if they don't become PET negative, possibly second line relapse, leading to an autologous stem cell transplant. And an autograft is very much standard of care for the majority of young patients who relapse with Hodgkin lymphoma. We'll talk briefly about maintenance, which isn't so much of an option in England anyway, but we'll still mention it. Then second line, second relapse. In this case, patients will have third line relapse treatment because they had 2 lines after their first relapse. Bridging usually to an allogeneic stem cell transplant. And then, of course, you can relapse after that and need 4th or subsequent lines of treatment. And I put in the box as well as a reminder that radiotherapy is a really important component of treatment at relapse. either before or after the autologous stem cell transplant, if you've got a localized area of relapse or a predominant sort of area of bulk. So first question, what's the risk for this patient who's relapsed? Well, Paul Brockerman from the German Hodgkin study group published a very good study in Annals of Oncology looking at 656 relatively recently treated patients who all had an autograft for their lymphoma and looked at risk factors for relapse. 5 were found on multivariate analysis. So stage 4, time to relapse of less than 3 months, a performance status of 1 or more, and bulk of 5 centimeters or more. Those are all factors at the point of relapse. In addition, an inadequate response to first-line relapse treatment was another risk factor. And you can see that for patients who scored all 5, their 5-year progression-free survival was only 35%. So those are the sort of risk factors that we think of. What's the second question? What's the optimum first-line treatment? Well, there sort of isn't any, because there still hasn't been any randomized trials looking at first relapse in classical Hodgkin lymphoma, which is a real shame. Now, in certainly England and most of the devolved nations as well, we have to use chemotherapy rather than targeted agents, and different centres use different chemos. And, I think what's most important is for the centre to be comfortable with the chemo it uses. So we tend to use GDP, other centres use ICE or ESHAP, or you can sort of, pay your money, take your choice. One thing to avoid, though, before you've collected stem cells is high-dose alkylating agents, so mini-beam or DexaBeam. I wouldn't use before collecting stem cells because they are stem cell toxic. And the aim of the relapse treatment is to try and get negative on a PET scan. Now, this was quite early data from 2010, showing quite convincingly that patients who became functional imaging negative, that's what FI is, that was mainly on a PET scan, but in this study there were some other functional scans which just aren't really used now. It was a gallium scan. If you became negative prior to the autograft, you had an excellent 5-year event-free survival of around 75%. So that's a cure rate of 75% plus. Whereas if you were positive still on your PET scan, it's not that nobody was cured, but you were down to about 30%. It's still okay to have an autograft if you have a positive PET scan, but your cure rate is going to be a lot less. So that begs the question, should you just go for the autograft, or should you give more treatment to try and get the patient PET negative? And that was addressed in this paper, came out a few years after the first, which looked at nearly 100 patients with relapsed classical Hodgkin lymphoma. After their first-line relapse chemo, which was ICE or augmented ICE, 60% had a negative PET, and of those that had second-line relapse treatment, in this case GVD, about half of those became PET negative. Now, the take-home message here is it didn't matter if you had 1 or 2 lines of relapse treatment. If you became PET negative, you did well. If you stayed PET positive, you did less well. So it supports this concept that trying to get a PET negative scan before an autologous transplant, it probably is of merit. The issue is partly, though, that PET scans are much more sensitive now than they were back in 2010, 2012. So do we really need a proper CR, or is a very good partial remission adequate? And we don't really have data to support decision-making in that particular context. So what happened with our patient? Well, he actually had ESHAP chemotherapy. Unfortunately, after 2 cycles, he did have Deauville 5 disease, FDG avid disease remaining. So the question is, would we proceed to an autograft now? And if not, what would you switch to? Well, to be honest, my general approach is if there is a good partial remission, perhaps a Deauville 4, then I think an autograft is perfectly valid. But if you've got proper stable disease or progressive disease, then I wouldn't go straight in with an autograft. I would try and get the patient in a better remission. So what would we use? Well, brentuximab vedotin is an option. We're now in the 3rd-line setting, and that's where brentuximab vedotin as monotherapy has a license and is reimbursed in England. And this is data from the original phase 2. Now, this data actually is all post-autologous stem cell transplant, but it just gives you an idea of the very high response rate that was seen, with a relatively modest complete response rate of 35%. Just to highlight safety, peripheral neuropathy is the issue with brentuximab vedotin. You do need to keep a close eye out for it. So brentuximab is an option. My colleague, Toby Eyre, co-course director, led on this real-world study that was published in 2017 in the UK, 99 patients. We were very gutted not to have the 100th. And we looked at brentuximab vedotin before a stem cell transplant in patients who were fit for a stem cell transplant. And brentuximab effectively bridged people to a stem cell transplant as the next treatment in about 1/3 of cases, about 35%. Another quarter or so had further treatment and then it's still a stem cell transplant. So overall, it was 61% who did achieve a stem cell transplant, but some patients using this strategy did not make it to a stem cell transplant, and their outcome was significantly worse. So BV is certainly an option to bridge people to an autograft. What about a PD-1 inhibitor, a checkpoint inhibitor? These are very active in Hodgkin lymphoma. Again, this is from one of the pivotal studies in the post-autologous stem cell transplant setting, but again, showing very high response rates. CR rates are relatively modest at about 25%, but the duration of remission, even the partial remissions, is generally longer than BV. So very active treatment. Now, should we use BV or PD-1 prior to an autograft? I should say that we can use a PD-1 inhibitor before an autologous transplant at the moment in England, although it's actually accessing pembrolizumab through the Cancer Drugs Fund, and this is going to be reassessed by NICE quite soon, so I hope we'll still be able to have access. So brentuximab or a PD-1 inhibitor? Well, arguments for brentuximab. Brentuximab is chemotherapy. It's targeted chemotherapy, so it's an antibody drug conjugate, but the antibody delivers chemotherapy in a targeted way, the MMA warhead. So brentuximab certainly is still chemo, and that's maybe an advantage because if it works, it therefore says that your lymphoma is still chemosensitive, and that increases your rationale that an autologous transplant will work. After all, an ASCT is simply chemo. Very predictable side effects. We know about neuropathy and neutropenia in a portion of patients. And the complete remission rate is probably slightly higher, I would argue, than a PD-1 inhibitor, pembrolizumab, at least in this setting. Arguments for a PD-1 inhibitor, though, although it's not chemo, if you look at data of autologous stem cell transplant following PD-1 inhibitors, they do appear to be very effective. And there is a thought now that PD-1 inhibitors may sensitize to subsequent chemo. So even though it's not chemo, it still probably does set somebody up quite nicely for an autograft. Often tolerated very well, but the immune side effects, which are not common, but can happen, like pneumonitis, colitis, they can be very unpredictable, which can be difficult. And partial responses are very durable, unlike brentuximab. If you have a partial response on brentuximab, you really need to get to the transplant quickly, whereas with a PD-1 inhibitor, you're in a bit less of a rush. So my approach, our approach in Oxford generally, is if a patient's still chemosensitive after first-line relapse chemo, but they've not responded well enough, we generally try brentuximab. But if they're chemo refractory, so they're stable disease perhaps, or progressive disease after first-line relapse, then we'd usually go with a PD-1, a non-chemo approach. And in this setting, it's pembrolizumab. So what happened with our patient? Well, he had brentuximab and achieved a complete metabolic response. I should say a checkpoint inhibitor wasn't available at the time this patient was treated. He did develop mild grade 1 peripheral neuropathy, but there were no dose reductions needed, and that bridged him to an autologous stem cell transplant very effectively. So I keep banging on about an autologous stem cell transplant, and that is still the standard of care in most patients who are fit enough with relapsed Hodgkin lymphoma. This is based on two fairly small studies. The Lynch study, this was a UK study, which showed an event-free survival advantage, but small numbers of patients, no overall survival advantage seen, and a larger European-wide study by Norbert Schmitz, which again showed a freedom from treatment failure advantage, but no overall survival advantage. So the two trials we have actually don't show an OS advantage. I think it's always very interesting looking back at these trials that support our standard of care, showing that actually the trial data is not hugely great for these interventions. So that's the data for the autograft. Now, what about giving treatment after an autograft, but without any relapse, so-called maintenance, or some might call it consolidation treatment? Well, this whole sort of area came to the fore with the ATHERA trial, which is one of the largest trials in relapsed Hodgkin lymphoma. This took patients who were given relapse chemo for a high-risk relapse. The high risk here was defined as refractory to frontline treatment, relapse within 12 months, or later relapse, but with extranodal involvement. That's how it was specified for the trial. Patients received salvage chemo, and I use that term because that's how it's used in this slide. And for those who responded and had an autograft, they were then randomized to a year of brentuximab vedotin or placebo. And this was phase 3 multi-center, blinded, placebo-controlled. And you can see a significantly prolonged progression-free survival. That was the primary endpoint. And the more risk factors you had at relapse, the wider that split. So this does seem to cure more people if you add a maintenance strategy. Just before I move on, in England, although this is licensed, this approach, it's not reimbursed. And that's was largely thought that actually patients, you could then sort of save your brentuximab for relapse. Personally, I think it's a shame, because if you do save your brentuximab for relapse, you're then generally bridging people to an allogeneic stem cell transplant, whereas with a maintenance approach, you're potentially avoiding the transplant. However, as brentuximab moves further up the treatment pathway, and in some countries even frontline, the role of maintenance brentuximab after an autograft is under some question. So I don't think it will ever become standard of care in the UK for those reasons, partly just simply lack of funds. So what happened to our patient? He didn't have maintenance because it wasn't available. But 9 months later, after the autograft, he complained of itch and fatigue, a lump in the neck that was palpable. You can see the PET scan here. He had no neuropathic symptoms, so the brentuximab hadn't led to any sort of long-lasting neuropathy, and otherwise he'd recovered from his transplant, and he was stage 3S at relapse. Well, as he had responded well to his brentuximab last time and he had no ongoing side effects, he was retreated with brentuximab, and that is something that is reimbursed in this country. After cycle 3, he did develop grade 2 peripheral neuropathy, which is relatively significant. So we dose reduced to 1.2 milligrams per kilogram, and dose reductions are really important if people do develop more than grade 1 neuropathy. And after cycle 4, he showed a partial remission. So the question is, what do you do now? Before we address that question, though, I just want to again ask, should we use a BV, brentuximab, or a PD-1 post-autologous transplant? I've shown you that pivotal data. Both were demonstrated in the post-autologous stem cell transplant setting to be very active. They have a license and a reimbursement there. And which agent we use really depends a little bit on what the patient had before. So this patient had brentuximab, he'd responded really well, no ongoing side effects. If he hadn't responded well to brentuximab or had ongoing neuropathy, then I would have gone definitely with a PD-1 inhibitor. So I think it depends a little bit on what a patient's had before and what their lasting toxicities are. Now, there has been a head-to-head trial, though, comparing brentuximab with pembrolizumab in relapsed classical Hodgkin lymphoma, the Keynote 204 study, so it's helpful to have this data. This was in patients who relapsed post-autograft or who were not eligible for an autograft for whatever reason. Either they were unfit or they were fit, but they just hadn't got into a good enough remission. It's a little bit odd because the control arm of brentuximab, you could have up to 35 cycles, whereas 16 is the licensed number. I've never, known anyone go up to 35. But I think it was just so it was balanced with pembrolizumab, where you allowed up to 35. And you could have also had brentuximab before and still be eligible for this trial, but there weren't many. So you can see there were over 300 patients randomized. And the bottom line is the median progression-free survival with brentuximab was 8.3 months. With pembrolizumab, it was 13.2 months. So it was a positive trial showing pembrolizumab had a superior progression-free survival. So it might make you think, well, anyone relapsing post-autologous transplant, we should use a PD-1 inhibitor. However, there are concerns about using a PD-1 inhibitor as a bridge to an allogeneic stem cell transplant, which I'll discuss more about in a moment. What is helpful, though, is that pembrolizumab does induce more durable partial remissions, which is much easier to get people to a transplant than, say, brentuximab, where the duration of remission, particularly in partial responses, is usually much shorter. So again, there are swings and roundabouts with each. So concerns of allografting, well, when pembrolizumab and nivolumab were first investigated, and I remember this well, there was a concern about hyperacute graft versus host disease, grade 3 or 4 acute graft versus host disease, or steroid-requiring febrile syndrome following an allogeneic stem cell transplant, and that has gone on the initial FDA label as a warning. And I think that's real. I think there is an increased risk of those complications following an allogeneic stem cell transplant. However, when you look at the data of patients receiving an allo after a PD-1 inhibitor, generally the outcomes are very good. So you can see here data from Merriman et al. Over 200 patients had a PD-1 inhibitor followed by an allograft. Some had other treatments in between. So 109 of those 209 went straight to an allograft and 100 had intervening chemo. And there was a median of 81 days from the PD-1 inhibitor to the allo. But you can see the 2-year PFS here is 69%. Now that's phenomenally good data from post-allogeneic stem cell transplant. So even though there is an increased risk of graft versus host disease, it doesn't seem to translate to worse outcomes overall. What I think most people do recognize is that you need very good anti-GVH prophylaxis, probably with post-transplant cyclophosphamide. That's associated with better outcomes. And you need a bit of a washout between your PD-1 inhibitor and your allograft, probably at least 6 weeks. But, the optimal interval hasn't really been defined. Now, I'm sure most of the audience here is aware of the theory of an allogeneic stem cell transplant. You not only sort of get a clean graft, but you also get a graft versus lymphoma effect, which certainly is an effect we see in an allogeneic stem cell transplant with Hodgkin. However, you can also get graft versus host disease, both acute and chronic. And I've just put here some data from a UK group who were looking at Beam Campath or Beam alemtuzumab allografts. This is still used quite commonly in the UK, 76 patients. And again, you can see that the 4-year PFS here is about 40%, but the 4-year current PFS, what that means is you can have relapsed, but then get donor lymphocytes only, no chemo, no radiotherapy, back in remission, and it doesn't count as a PFS event. Bit of a fudge maybe, but I think there's a rationale for reporting it, was around 60%. So it is a very active approach in multiply relapsed Hodgkin lymphoma, and probably I think still is the only curative approach we know of in patients relapsing post-autologous stem cell transplant. So should you allograft or not in a relapsed post-autograft? Well, as I say, about 40 or 50% of patients are cured, even though they've got quite difficult disease. And we've got much longer follow-ups than other approaches, such as just carrying on the PD-1 inhibitor. And in fact, the longer follow-up we get with PD-1 inhibitors, the less I'm convinced we're curing many people at all with it. Very good remissions, yes, but probably not cures. Against allograft, well, of course, there's a 10 to 20% transplant-related mortality rate. You may get chronic graft versus host disease, which impairs quality of life, and it may reduce the availability of other agents, such as CAR T cells on trials. There's no standard of care available CAR T in this setting. So my view is that I would almost never now go for an allograft before an autograft, as even if you autograft a partial remission, actually you can do well in about a third of patients. But for those who do relapse after an autograft, I'll usually recommend an allograft, but more and more patients are saying, no, thank you. I feel fine on my PD-1 inhibitor. I'm just going to continue that. So it does need to be a discussion with the patient. So here is that timeline which I've filled in. Patient from diagnosis gets frontline treatment. First relapse, it's still chemotherapy. Either, I say GDP is often what we tend to use, but it can be in other different types. If you're PET positive still at that stage and want to get into a better remission pre-autograft, it's really either brentuximab or pembrolizumab. You could use alternative chemo, but it's not particularly going to work better than the first line relapse chemo you've given. Maintenance with brentuximab I've put in brackets because that's not routinely available or routinely reimbursed at least. And if you relapse after your autograft, it's a PD-1 inhibitor, usually nivolumab in this setting, at least in England, or brentuximab. And then, of course, if you relapse after your allo, there really is no standard of care beyond donor lymphocyte infusions. But again, I emphasize radiotherapy as a component of this pathway. Very important to involve your clinical oncologists in a discussion of any relapsed Hodgkin patients. Some points to note: BV, so brentuximab and PD-1 inhibitors, are only licensed as monotherapy, but we know from various phase 2 trials that the response rates you see when you combine either BV or a checkpoint inhibitor with chemo are really very impressive. And if I could give a patient anything I wanted, I would nearly always combine with chemotherapy. Some centres in the UK can do that, such as give brentuximab and bendamustine. Others can't. It's a bit of a postcode lottery, I'm afraid. I've presented here what is licensed and standardly reimbursed across England. Don't forget radiotherapy again. For very low risk disease, such as where you've had early stage Hodgkin lymphoma initially, you've not had radiotherapy, and then you relapse in a previously involved site, then actually you don't necessarily need an autograft in that setting. Further chemo and radiotherapy may actually cure a patient. So there are some low-risk patients where you might not necessarily need an autologous transplant. And very late relapses, it's quite hard to know what to do with these patients. There's some evidence that actually this may be a clonally unrelated round of Hodgkin lymphoma. Although, to be honest, usually an autograft, certainly in my practice, is usually still what we head for in that setting. I've got very small amounts of slides really to talk about older, less fit patients, very important group though, with relapsed disease. And it's a little bit more straightforward because obviously these are by definition unfit for an autologous transplant. That's what this pathway applies to. So at first relapse, again, we have to go for chemotherapy. Often I'll use single agent gemcitabine, as they've not usually had gemcitabine up to this stage. Then when they relapse again, I usually go for pembrolizumab. The reason I do that ahead of brentuximab is we know it's associated with a longer progression-free survival. And a general principle in cancer medicine is your longer remission duration agents are usually better the higher up the treatment pathway you give them. So I usually go for pembrolizumab then, and then at a third relapse, I go with brentuximab. And then after that, obviously, there's really no standard. And again, I highlight very important, even more important possibly in older patients, is to consider radiotherapy. Obviously, late effects, much less of an issue in older patients, particularly late cancer effects. So again, clinical oncology input. And our aim here isn't so much cure, it's prolonged quality of life. So my take-home messages would be that in younger people, we're after cure. We aim for a complete metabolic remission if we can with first or second line therapy. The first line is combination chemo. The exact type really isn't necessarily defined. Second line is usually one of these more targeted inhibitors, BV or a checkpoint inhibitor with chemo if you can, but many centers were not allowed to do that. Autologous transplantation cures around 3/4 of patients if they're in a CMR before they're autograft. Relapse post-auto, it's brentuximab, which could be retreatment or a PD-1 inhibitor. We've talked a little bit about what would make you choose between those. And there is some concern about allografting after a PD-1 inhibitor, but the outcomes are still very, very good. And remember radiotherapy. Then in older patients, auto unfit patients in particular, our aim is quality of life and prolongation of life. Currently, we still have to use chemotherapy at first relapse, such as gemcitabine, and then at second relapse, I tend to use a PD-1 inhibitor due to that prolonged PFS, and then brentuximab as third line. So I hope that's clarified the approach to treating relapsed classical Hodgkin lymphoma. It's a relatively rare, as I say, and relatively complicated treatment pathway involving some very interesting therapeutic agents. So thank you very much for listening.
My name is David Cutter. I'm a consultant clinical oncologist at the Oxford Cancer Centre and an associate professor at the University of Oxford. Many thanks to my colleagues, Graham and Toby, course directors, and the Lymphoma Action team for inviting me to speak as part of this course. I've been asked to speak about radiotherapy, weighting the risks and benefits. This topic is also relevant for the management of non-Hodgkin lymphoma, but as this is a Hodgkin lymphoma day, for the purpose of my talk, I will focus on the challenge in the context of Hodgkin lymphoma. So it's always nice to start with a bit of history, and this is your reminder that radiotherapy is the oldest active agent in the treatment of Hodgkin lymphoma. It's been used for more than 120 years now. And this is also a neat reminder that when chemotherapy fails, which is actually intratumoral arsenic in this case, radiotherapy can still be very effective. This is the oldest recorded palliative treatment with radiotherapy, and allowing the patient to play billiards again is obviously a relevant patient-reported outcome measure for this individual. Chemotherapy and radiotherapy have both dramatically improved since this time. Indeed, through the early 20th century, radiotherapy techniques were refined so that by the publication of this seminal paper from Henry Kaplan in 1962, it was possible to use radical extended field radiotherapy, as seen on the right there, a port film from an early mantle field, to achieve 10-year progression-free survival rates of 70 to 80% in patients with localized disease. And this can be seen from this very early example of a Kaplan-Meier curve. Note that this is a different Kaplan though, it's Henry, not Edward, who did the radiotherapy. Treatment further evolved with the addition of multi-agent chemotherapy, and you can see from this classic paper on all-cause mortality following treatment for Hodgkin lymphoma from the Netherlands that death from Hodgkin lymphoma plateaus at around 20 years following diagnosis and is soon overtaken by deaths from other causes. This is principally from second cancers and cardiovascular disease. Now, a large component of these excess risks is in fact due to chemotherapy exposures, particularly older alkylating regimens and the introduction of anthracycline chemotherapy in the 1970s. But as it had been used for so long and initially as a single modality, there were already well-established associations between radiotherapy use and these delayed mortality risks, which led to a drive to improve radiotherapy techniques. And radiotherapy certainly has changed over the decades with dramatic reductions in volumes and doses. On the left here, we have an old-fashioned mantle field, which would have been delivered with a prescribed dose of 30 to 40 gray. And on the right, we have a contemporary involved site radiotherapy field, where just the original extent of the disease with a margin is treated to a dose of 20 to 30 gray for early stage disease. The most recent drive has been to safely omit radiotherapy entirely, principally using PET-CT as a guide to doing so. And summarized here in very broad terms is the current state of play regarding radiotherapy in the management of Hodgkin lymphoma. In early stage favorable disease, the decision is between a chemotherapy-only approach or combined modality therapy. This is probably the most controversial decision and the focus of the rest of this talk. For unfavorable early stage disease, there's the German Hodgkin study group approach, HD17, 2+2 chemotherapy with radiotherapy only being used if there is PET positive disease at the end of chemotherapy. And then there's the EORTC or RATHL approach, where the choice is between 4 cycles of ABVD and radiotherapy or 6 cycles of chemotherapy. And the decision between those two can be made as per individualized risks if the patient is PET negative. For advanced disease, historically patients in an anatomical complete response on CT after chemotherapy did not benefit from radiotherapy. 2 more recent Italian trials of radiotherapy to bulky sites in patients who were in a complete response on PET after ABVD chemotherapy showed statistically non-significant increases in progression-free survival of 4% and 7.5%, and an unplanned analysis of RATHL showed a possible benefit of radiotherapy after ABVD for those patients with a positive PET at interim. But essentially, the use of radiotherapy after ABVD for advanced disease, if they are PET negative, is highly selective, not routine, and on an individualized basis on factors such as tumor bulk, speed of response, and disease distribution, with the decision to be made in this case being whether the approximate 5% progression-free survival benefit exceeds the individualized risks. After more intensive chemotherapy approaches, such as escalated BACOP, radiotherapy use is only standard if there is PET positive residual disease of more than 2.5 centimeters at the end, again, the German Hodgkin study group approach. For relapsed and refractory disease, arguably radiotherapy still remains the most active single agent for Hodgkin lymphoma, and it's perhaps underused. So I would encourage its consideration of its use for localized relapses or bulky or slowly responding sites of disease. And the balance of benefits versus risk is really very different in this context. Cure becomes paramount, and radiotherapy should really be used wherever appropriate. Shifting the focus to early favorable disease, what happens if you omit radiotherapy in patients who have a complete metabolic response to initial chemotherapy? Well, there have been 3 randomized control trials that have asked this question and have given a similar answer. We have the UK RAPID trial, the ORTC H10 trial, and the German Hodgkin study group HD10 trial, all of which randomized patients to receive radiotherapy or not following initial ABVD chemotherapy. And the result in each trial was similar. There was an increase in relapse following omission of radiotherapy, with a progression-free survival advantage with radiotherapy varying between 6.3 and 11.9%. A meta-analysis of these 3 studies gave a hazard ratio of 2.77. So although there is differences between these trials in terms of the precise inclusion criteria, the timing of the PETs, the number of chemotherapy cycles, and the radiotherapy techniques, the bottom line is really that there is a proven benefit from receiving radiotherapy if a patient is PET negative. And although the absolute relapse risk is low, it's 2 to 3 times higher if you do not use radiotherapy, and this equates to an approximate 6 to 12% absolute improvement in progression-free survival with radiotherapy use. So we know that radiotherapy reduces the risk of relapse, but as there are many second-line treatments available for Hodgkin lymphoma, a big question is whether it actually improves overall cure or overall survival. Now, these trials were not powered to demonstrate an overall survival benefit. They didn't have the numbers or the length of follow-up required. And any effect on overall survival is expected to be delayed and smaller than a progression-free survival benefit. So what other data do we have available to consider this question? Well, there's some good observational data. This is data from the US National Cancer Database, more than 28,000 patients with early stage Hodgkin lymphoma treated with either chemotherapy alone or combined modality therapy from 2004 to 2018. Interestingly, combined modality therapy use declined from 58 to 34% over this period, but with a median follow-up of 6.2 years, by which time the majority of deaths from Hodgkin lymphoma will have occurred, there was a 5-year overall survival benefit for combined modality therapy versus chemotherapy alone of 3.6%. Now, this advantage has narrowed slightly by era, perhaps due to better patient selection with PET or chemo escalation, but the 10-year overall survival also showed a benefit of 4.8% with combined modality therapy. This data supports the fact that the suggestion that there may be an overall survival benefit from combined modality therapy in the longer term, but this comes with the usual caveats of observational data, selection bias, for example, the fact that longer follow-up is really needed to fully assess the late effects of radiotherapy, and consideration of the facts that new systemic treatments are becoming available and radiotherapy techniques have improved. But really the residual question is not if radiotherapy works, it's proven to work. It's how do we weigh and balance the proven benefits versus the predicted risks from radiotherapy in the modern context, the benefits being primarily a reduction in relapse risk, but also perhaps a reduction in chemotherapy and avoidance of relapse treatment. The risks primarily being cardiovascular disease and second cancers, although there are some others such as the acute side effects of radiotherapy and hypothyroidism. The question is, can we individualize the decision to withhold radiotherapy if a patient is PET negative following chemotherapy? As a follow-up to the RAPID trial, we conducted a study looking to predict the cardiovascular toxicity of treatments within the trial, which was published a couple of years ago. So these were patients, 144 patients treated within the radiotherapy arm of the study. We got cardiovascular radiation doses to the heart, carotid arteries, cardiac substructures. Combine these doses with the relative cardiovascular disease risks as assessed by cohort and case control studies obtained within the Dutch Hodgkin lymphoma survival cohort, and also absolute cardiovascular disease risks from the contemporary UK population to give us background baseline mortality and incidence rates, and combine these doses and these risks to produce predictions of 30-year cardiovascular disease mortality and incidence. This is what we found in terms of radiation doses to the heart and the coronary arteries. In terms of the heart, the average heart dose in the whole cohort was 4 Gray. In patients with no mediastinal involvement, in the light blue here, as you may expect, the dose to the heart was much lower, less than a Gray, whereas those patients with mediastinal involvement received a higher average mean heart dose of 7.8 Gray. But there was a wide range here from less than 1 Gray up to more than 20 Gray, which reflects difference with the extent of involvement and the size of the radiation fields. To put these doses in a historical context, a historical mantle field with a prescribed dose of 30 to 40 Gray would give around 20 to 26 Gray to the heart. And to put it in the context of a more modern, sophisticated radiotherapy treatment, involved node radiotherapy and DIBH, and this line at the bottom here is from a cohort study conducted at the MD Anderson, gave heart doses of less than a Gray, with 33% of that cohort having mediastinal involvement. On the right, we have the doses to the common carotid arteries, which shows a bimodal distribution, with those on the right receiving the doses around 30 Gray being patients who received bilateral neck irradiation. And when you convert these doses into predicted risks for the cohort, this is what we saw. On the left is the predicted cardiovascular mortality, and on the right, cardiovascular incidence. The black line is what would be expected for the age and sex matched UK population. The orange line is the increased risk predicted from anthracycline exposure. And on top of this, the blue line is the additional risk predicted from radiotherapy exposure. So you can see that on average, the predicted risk from radiotherapy was actually less than the predicted risk from anthracyclines. But for individuals, this ranged from virtually no risk at all up to really very substantial risks from radiation doses to the heart and neck. If you sort the patients by excess risk from radiotherapy and look at the variation between individuals on the left and the effect of irradiating proportions of the population at lower risks on the right, you can see that the 30-year mortality risk from cardiovascular disease was less than 1% in 85% of individuals. And there was an average of just 0.11% mortality risk in the lower risk 50% of the cohort. Similarly, for incidence, the incidence risk was less than 5% for 3/4 of individuals, and the average was just 1.79% in the lower risk 50%. So in conclusion, in the RAPID cohort, for the vast majority, the benefits of radiotherapy in terms of reducing relapse risk outweigh these cardiovascular risks. And it's important to remember that these risks in a more modern cohort will be lower still, with 20 Gray prescribed dose for early favourable disease rather than 30 Gray, for involved site or involved node radiotherapy rather than modified involved field radiotherapy, which was used in RAPID, and also by using advanced radiotherapy techniques such as DIBH and proton beam therapy. Similar arguments and calculations can be made for second cancer risks. Organ doses with modern treatments are much lower on average, often less than a third if they were with historical treatments, but there is still this variability with a large range, and again, this opportunity to individualize the use of radiotherapy based on the predicted risks. So lung cancer, for example, with a historical mantle field, the lungs would have received radiation doses of 13 to 18 gray, whereas in the rapid cohort, the doses to the lungs were about 4 gray on average, less than 2 gray for half of the patients. So the risks of lung cancer would be expected to be similarly reduced, so approximately a quarter. And this is because there are these linear, no threshold relationships for radiation-related second cancers. Similarly, with breast cancer, historically, the high breast radiation exposure has been from the axillary parts of the mantle fields rather than the mediastinal part. For a historical mantle field, the radiation dose to the breasts would have been about 12 to 16 gray. But if you exclude the axillary fields, this drops to around 4 to 6 gray, which is only around 37% of the dose to the breasts. And in this Hodgkin lymphoma survivor cohort, the Netherlands cohort, they compared supradiaphragmatic radiotherapy without auxiliary radiotherapy to mantle radiotherapy and found a hazard ratio for breast cancer of 0.37, corresponding to the dose reduction seen. So far, I've only talked about variation in risks. What do we know about variation in benefits for radiotherapy amongst those patients who are PET negative? So this study, again from the RAPID trial, was published a few years ago. They analysed the risk of relapse by maximum tumour dimension, MTD, at diagnosis and found a significant association between MTD and relapse with a hazard ratio of 1.19 per centimetre MTD. So in other words, the relative risk of relapse increased by 19% per centimetre as a linear continuous variable. So that would look like this, with the relative risk of relapse increasing linearly with the MTD. An analysis was done to look at the effect of MTD cutoffs on relapse risk, and this was found to be statistically significant at equal to or greater than 5 centimetres. And this was given as a rationale for the use of 5 centimetres as an indication for radiotherapy within the RADAR trial, the successor to RAPID. But if we accept the association seen on the previous slide, the linear association, what are the implications for using 5 centimetres as a cutoff for clinical decision making? On the top here, we have the distribution of 210 patients by the MTD groups. And if we assume the statistically significant relationship between MTD and relapse is real, and fix the number of relapse events observed, which was 10% or 21 relapses in 210 patients, and then model the expected distribution of relapses over the MTD groups according to these assumptions, we get what we see at the bottom left, which is the observed relapses in blue and the model relapses in red. So it's very likely that the statistical significance at the 5 centimetre cutoff is just due to this random variation in the distribution of a small number of observed events rather than any special significance of 5 centimetres. It's possible there may have been some radiology reporting bias of 5 centimetres on diagnostic scans, as this was known to be a prognostic size. So what happens if we model the observed effect of radiotherapy using a hazard ratio of 2.36 as per the RAPID protocol analysis? What happens to the incidence of relapses? This is what we'd see in terms of the cutoffs. If you had no cutoff at all and treated all patients as per protocol radiotherapy arm, you would expect a 5.7% improvement in progression-free survival, which is actually very similar to the observed trial result. If you had a cutoff at 5 centimetres, you would treat only 18.5% of the patients, but they would gain a 7.9% improvement for those patients. But you'd only be preventing around a quarter of the relapses that could have been prevented by radiotherapy. In between, for example, a cutoff of 3 centimetres, you'd be treating half the patients, and you would give them a 6.7% reduction in relapse risk, and you would be preventing 60% of the possible recurrences in the cohort. So really the appropriate clinical cutoff is where the absolute risks in the proportion treated become greater than the absolute benefits from reduced relapse. And it's very unlikely that this optimal cutoff is going to be 5 centimetres either on average or in individual cases, as the risks vary by so many other factors and so widely. So it's not really logical to make a decision based on the benefits alone or the MTD alone without considering or balancing the individual risks. If we look at the benefits of radiotherapy by groups rather than by cutoffs, this is what we see. An increasing progression-free survival benefit with MTD group reaching more than 7% for an MTD of 5 to 6 centimeters, which coincidentally is the non-inferiority margin that was chosen for the RAPID study. And this is arguably a better rationale for using this same cutoff in RADAR as the successor to RAPID. In other words, we'd expected progression-free survival detriment of less than 7% for the patients with an MTD of less than 5 centimeters treated with 3 cycles of ABVD alone in RADAR compared to those treated with combined modality therapy, although this detriment may of course be less in the brentuximab arm. A quick word on Deauville 3 patients. Deauville 3 patients in RAPID were treated with 4 cycles of ABVD and radiotherapy, and they did just as well as those who had a Deauville 1 to 2 response. And this US study, looking at 4 cycles of ABVD with no radiotherapy, inferior outcomes were seen for Deauville 3 patients compared to Deauville 1 to 2 patients at interim PET scan after 2 cycles, with really quite a substantial difference, 77 compared to 94% 3-year progression-free survival. So will the D3 patients treated with 3 cycles of ABVD alone also do less well? Well, this question is complicated by changing PET techniques, changing algorithms and the sensitivity of PET scans. Other data suggests that Deauville 1 to 3 is now generally considered to be PET negative, although it may be the case that these D3s are less positive. RADAR is using a D1 to 3 cutoff to define PET negativity, but the results for the D3 patients in this study will be closely monitored. So we've talked about the risks of radiotherapy and the potential benefits of omitting radiotherapy, but what about the benefits of radiotherapy in terms of allowing a reduction in chemotherapy exposure? Well, for early stage favorable disease, the choice is really between 2 cycles of ABVD and 20 gray radiotherapy versus 3 ABVD. So radiotherapy allows you to reduce the acute toxicities from chemotherapy as one fewer cycle, and also reduce the anthracycline dose, which would be expected to lead to an approximately 18% relative reduction in the heart failure risk. For early stage unfavorable disease, the choice is between 4 cycles of ABVD and 30 gray versus 6 cycles of chemotherapy. So the benefit from using radiotherapy would be, again, reducing the acute toxicities from chemotherapy through 2 fewer cycles, and a reduced anthracycline dose, 2 cycles fewer, leading to an approximately 50% relative reduction in the heart failure risk. More intensive chemotherapy strategies, such as escalated BACOP, minimize the use of radiotherapy, and they may arguably give some better outcomes in higher risk patients. But they do come at the price of acute toxicities. You need to be younger and fitter to tolerate these more intensive chemotherapies, and there are perhaps increased risks to fertility from more intensive chemotherapy. So a benefit of using an ABVD and radiotherapy combined approach is perhaps avoiding these more intensive chemotherapy strategies. So how do we put it all together? Well, this is perhaps where health economic methods can help. Balancing competing benefits and risks over the decades following treatment is about more than just simply comparing the numbers, the absolute quantities of benefits and risks. You have to think about the quality of life effects of events, the timing of events, and perhaps even the financial costs of events. David Jones published this health economic analysis a couple of years ago within our group. So it's a microsimulation model of the effect on quality adjusted life years from combined modality therapy versus chemotherapy alone, either RAPID strategy for early stage Hodgkin lymphoma. This was a full life course assessment that included the most important radiation toxicities, breast cancer, lung cancer, ischemic heart disease, and stroke, but admittedly not all. For example, hypothyroidism was not included, but assessed a range of patients in terms of age, male and female, smoking status, and a range of organ at risk doses comparable to the doses to the organs of interest as seen in the RAPID study. This was also done with or without a 3.5% discount on future health costs. Now, this is a commonly used health economic principle where events that happen further in the future matter less in terms of the quality analysis than events that happen sooner. And these were the conclusions. Combined modality therapy was seen to be superior for nearly all never smokers, regardless of age, sex, or organ at risk doses and future discounting or not. It was very strongly affected by age. Perhaps counterintuitively, combined modality therapy was favored for younger patients, and this was due to the lower background risks of diseases and the higher cost of a relapse at a young age. The future discount rate favored combined modality therapy, which is not really very surprising as radiation late effects are delayed. They are late. And smoking strongly favoured chemotherapy only, as smoking markedly increased the risks of lung cancer and cardiovascular disease risks from treatment. But again, we see this effect of a wide range for individuals with the same diagnosis and treatment. So on the left here, we have an example of a 20-year-old male who's a non-smoker and who has just unilateral neck disease, which was about a third of the patients who were treated in RAPID. And radiotherapy would be estimated to give a 1.1 QALY gain for this type of individual. Whereas on the right, we have again a 20-year-old male, but this one is a current smoker with bilateral neck and extensive mediastinal disease, which was very much the minority of patients seen in RAPID. But if you gave radiotherapy in this example, you would predict a 3.5% QALY loss from the radiotherapy treatment. So weighing up the benefits and risks in early stage Hodgkin lymphoma can be very challenging. What can we do to try and make it easier? Well, we're working on predicting radiation doses up front to facilitate the initial decision regarding radiotherapy at diagnosis. And it may be that you can use the diagnostic PET scans to predict doses to the heart, the lungs, the breasts, etc., to include in the decision-making process during MDTs. There is the possibility of producing an individualized decision aid, perhaps as an online tool, which could provide versions of the benefits and risk estimates or health economic analyses for clinicians and patients to use. But this would be a challenge. It would need to be completely comprehensive and would need to include all the relevant treatment risks, individualized by organ at risk doses and chemotherapy use, all the relevant comorbidities, particularly smoking, and would also ideally individualize the radiotherapy benefits as well as the risks using MTD or other biomarkers. And importantly, it would need to be appropriate for shared decision making. Even with all the information at your fingertips, making these decisions in an appropriately shared manner with your patient can be very challenging. So in conclusion, who benefits from radiotherapy in early stage Hodgkin lymphoma? Well, my opinion is likely a considerable portion, probably more than currently receive radiotherapy. And the future of radiotherapy involves improving individualization to allow the appropriate use of radiotherapy techniques in the most optimal way for individual patients. It's important to remember that not all patients are the same, and PET alone cannot make the decision. There are certainly low risk patients, for example, unilateral neck patients, and other favorable treatment volumes with low predicted organ doses. Non-smokers are at lower risk, and perhaps actually younger adults due to their lower absolute risks, with the possible exception of breast cancer, where the relative risk is very high for breast radiation exposure in teenage and 20-year-old women. There are also higher benefit patients, those with larger MTDs, certainly more than 5 centimeters, but treatments at lower MTDs could also be optimal for some individuals when balanced against the risks. Maybe Deauville 3 patients, if you're uncertain about the indication for radiotherapy, if they were Deauville 3 rather than 1 or 2, that may perhaps tip the balance in favor of radiotherapy. And there may be other future methods such as blood or imaging biomarkers that might aid the decision. It's also important to consider which individuals might be less likely to tolerate relapse treatment, for example, over older patients, and those 60 years or older are another indication in the RADAR trial to consider radiotherapy use. In terms of those people who should definitely not be for radiotherapy, I mean, certainly smokers with very extensive treatment volumes have very high risks, and I would not advise using radiotherapy in that context, but this is actually only a small proportion of the patients with early stage Hodgkin lymphoma. It's important not to forget the personal patient preference for optimizing their short and medium term outcome in terms of reducing the risk of Hodgkin lymphoma relapse over the long-term risks, which are often a largely theoretical concern to patients at that stage in their treatment pathway. All these considerations are, of course, likely to change as new treatments are brought into the first line, such as brentuximab within the RADAR trial. Thank you very much for your attention.
Hi, my name is Pam Mackay. I'm a consultant haematologist at the Beatson West of Scotland Cancer Centre in Glasgow, and I'm going to talk about nodular lymphocyte predominant Hodgkin lymphoma. Quite a number of topics discussed over a very short period of time, including background and natural history, pathology, is this really a Hodgkin's or non-Hodgkin lymphoma, the management of both early and advanced stage, and also future directions, just mentioning the new prognostic score. So NLPHL accounts for about 5 to 10% of cases of Hodgkin lymphoma. It's uncommon, with an incidence of 0.1 to 0.2 per 100,000 per year. It affects both adults and children, and it differs from classical Hodgkin lymphoma in a number of ways. The median age is older at 39 years. It's more common in males in a ratio of 3 to 1. It usually presents as early stage, and usually it's peripheral lymphadenopathy with few adverse prognostic features, and mediastinal disease is uncommon. The disease usually behaves in an indolent fashion, but late relapses can occur, and it may transform to high-grade disease. And a number of risk factors of this have been identified, including advanced stage, splenic involvement, and variant patterns. The incidence in the literature varies between 6 to 14%, and usually survival is good, with a 5-year overall survival around 90% or above. Deaths from NLPHL are uncommon, so it's really important that we consider toxicities related to treatment, as this can affect mortality, both second malignancies and non-malignant causes. And this is a paper from Eichenhauer in 2020. And these patients were mainly treated in German Hodgkin studies. So the treatment usually involved chemotherapy in the form of ABVD, BCOP, very rarely escalated BCOP, and radiotherapy. And what is the important thing to highlight here is that the minority of deaths were due to NLPHL. So 9.1% of patients died, under a quarter were due to NLPHL, just under a half due to secondary malignancy, and then 30% due to benign causes, but possibly related to treatment. And we look at the prognosis for these patients with NLPHL, there's some data here on the left-hand side of the slide from the Swedish Lymphoma Registry over a 14-year period, just under 160 patients. And you can see that overall survival for the whole group is excellent, over 75% at 15 years. And survival, not unexpectedly, is better for those with early stage disease. We carried out a retrospective UK study from 3 areas, west of Scotland, Nottingham, and HMRN in Yorkshire. This was published in 2019. Again, just over 200 patients, follow-up median 8.4 years, with excellent overall survival of 97% at 5 years. And this is a more recent study. This was published or presented at the ICML in Lugano this year by Michael Binkley. And this is the GLOW data, which is the Global NLPHL1 Working Group. This is a collaborative group internationally. It's just under 40 centres, and they collected data in over 2,000 patients. This includes both paediatric and adult patients. You can see the progression-free survival is excellent, 82.9% at 5 years, 71.1% at 10 years, with overall survival 96.3% and 91.7% at 5 and 10 years respectively. And transformation rate was 2.8% at 5 years and 4.9% at 10 years. And the patients in this study group were treated, about 30% had chemotherapy, 30% had radiotherapy, and similar numbers had combined modality treatment. So just looking at the pathology, NLPHL remains under the family of Hodgkin lymphoma in the most recent WHO classification published last year. However, in the same year, there was also a publication from the International Consensus Classification of Mature Lymphoid Neoplasms, and the suggestion was that the nomenclature should be changed to nodular lymphocyte-predominant B-cell lymphoma. And this is because there are major biological and clinical differences from classical Hodgkin lymphoma. The neoplastic cells have a functional B-cell program, and there is a close relationship between NLPHL and T-cell histocyte-rich large B-cell lymphoma. The malignant cells in NLPHL are the LP cells, and they strongly express some, although not all, B-cell markers, usually positive for CD20, CD79A, and OCT2. They are negative for the Hodgkin's markers, CD30 and 15, and they're rarely positive for EBV. Often we can demonstrate resetting follicular helper T cells, which express CD3, 4, 57, and PD1. Sometimes it can be difficult to diagnose NLPHL and separate it from progressive transformation of germinal centres, lymphocyte-rich classical Hodgkin's, or T-cell-rich B-cell lymphoma. And for this reason, we always prefer to have an excision biopsy rather than a core. A number of immunoarchitectural patterns have been described. Initially, this was way back in 2003 by Fan et al. The typical pattern, which accounts for about 75% of cases, are patterns A and B. And these are usually associated with early stage disease, Under 2% has stage 4 disease, and relapse tends to be later. Only 6.5% had relapsed in 5 years. Patterns C to F are described as variant patterns, and there's a higher incidence of stage 4 disease, accounting for 11.4%, and a higher relapse rate, with 18.1% relapsing in 5 years. And Michael Binkley again presented it in the ICML this year, data from the GLOW study, and they found an increase in proportion of stage 3-4 patients for patients that had a pattern D and E, which was highly significant. That the immunoarchitectural pattern was not significantly associated with progression-free or overall survival, but pattern E was significantly associated with an increased risk of transformation. So although there's interest in the pattern, it does not currently influence management. So how do we manage these patients? So looking first at early stage disease, stage 1 and 2A, which, as we said previously, is the majority of patients, there's a number of options, including active surveillance or watch and wait, radiotherapy, chemotherapy, combined modality treatment, or immunotherapy. Active surveillance is mainly seen in the paediatric approach. So these children often get the node completely excised, and overall survival is excellent at 90 to 100%, with no overall survival benefit from the addition of therapy, including radiotherapy, chemotherapy, or combined modality, although these additions may improve progression-free survival. In our UK retrospective study mentioned earlier, in early stage patients, just under 11% were managed by active surveillance, with very good 5-year progression-free survival at over 70% and overall survival of 96.7%. There's also some data from Memorial Sloan Kettering, as 163 patients between 1974 and 2016. There's a mixture of early and late stage here, but 23% were managed with active surveillance, with very good progression-free survival. Overall survival was identical, whether they were treated or not, and only 7 deaths were reported, with just 1 due to lymphoma. So this suggests that watch and wait is a very reasonable approach for asymptomatic patients. There are no randomized control studies on radiotherapy in this entity, but there's been a number of studies published over the years of varying size, and most patients with early stage disease, the results are similar, with 70 to 90% freedom from progression at 10 to 15 years, and overall survival 75 to 100%. And the usual dose is 30 gray, involves site radiotherapy. Chemotherapy is a number of options are available. These may be in the kind of Hodgkin type, ABVD, or non-Hodgkin's CHOP, or CVP, with or without rituximab. The support for a chemotherapy alone approach is mainly from paediatric studies. Anna Shankar published back in 2012 a study giving CVP when vinblastine is used rather than vincristine in the paediatric setting, 3 cycles with 75% freedom from treatment failure and 100% overall survival at 40 months. Results in adult studies have not been so encouraging. And in our UK study, there was 15 patients, 11 of which at early stage received CVP, with 5-year overall survival 100%. These were mainly younger patients with a median age of 16 years, reflecting that this is mainly a paediatric type approach. But what it does suggest is that we can get good results with CVP, and anthracyclines may not be required. So looking at combined modality therapy, both combined modality therapy and radiotherapy are associated with good long-term outcomes. And combined modality therapy may improve the progression-free survival, but there is, of course, additional toxicity. So a study in 2004 using short course ABDV-like chemotherapy with radiotherapy had an 80% 15-year freedom from progression and 86% overall survival, which are similar to the results for the radiotherapy alone. And another study showed no significant additional benefit from combined modality treatment, with similar overall survival rates to radiotherapy alone, at just under 90% at 15 years. And a paper back in 2015, looking at a number of Hodgkin studies, HD4, HD7, HD10, and this is a retrospective analysis which showed no significant difference in overall survival or failure from treatment failure between extended field radiotherapy, involved field radiotherapy, or combined modality treatment, again supporting the use of radiotherapy alone in this setting. What about rituximab monotherapy? This is a study, it's a small phase 2 study, just under 40 patients. Patients received 4 weekly doses of rituximab, and then later this was modified to include maintenance rituximab. It was a mixture of previously treated and untreated patients. And the response rates were excellent, with 100% overall response rates to 4 infusions, 67% CR, but the progression-free survival was suboptimal. Those that got induction alone, 5-year progression-free survival was 39%. It was 59% when they had maintenance. And basically, rituximab monotherapy is known to be active and well tolerated, but the responses are not very durable and they're inferior to both radiotherapy and combined with modality therapy. So again, further data from Michael Binkley. This is more recent data published in 2019 in an international retrospective study, just under 600 patients, typical demographics with a median age 39 years, 75% male. Patients had stage 1 or 2 disease, and 46% received radiotherapy alone, just under 40% received combined modalities treatment, and only 8.4% received chemo alone. And the chemotherapy used was mainly ABVD with or without rituximab, or R-CHOP. I just want to highlight the 5-year progression-free survivals for radiotherapy alone at 91.1%, compared with the combined modality treatment at 90.5%. Chemo alone has suboptimal results at 70.5%, and the results for observation were excellent at 74%. So my approach for the management of early stage NLPHL is that if the disease is resectable, then the patient will have surgery and then active surveillance. For patients with stage 1 or 2A and up to 2 sites of disease, we offer radiotherapy. And for patients with stage 2A that are not suitable for radiotherapy alone, we treat as advanced stage, and that would usually in our setting be with RCVP. And this is obviously adults. I don't manage pediatric NLPHL. When it comes to advanced stage disease, which are including 2B, 3 and 4, this accounts for under a quarter of the patients. It's important to consider whether there's any suggestion of high-grade transformation. And in particular, this should be considered in patients with stage 2 who've got B symptoms, if there's splenic involvement, or if there's bone marrow involvement. And this graph from a paper from Zing in 2014 shows the increased risk of histological transformation with splenic involvement at 29% at 10 years, compared with 7.8% in the patients that did not have splenic involvement. Active surveillance may be appropriate in advanced stage NLPHL, similar to follicular lymphoma and other low-grade lymphomas, if the patients are asymptomatic. And in our UK study, 20.4% were managed by active surveillance. All of these were stage 3 patients, and the outcomes were excellent, with 70% 5-year progression-free survival and 100% overall survival. And the Memorial Sloan Kettering study had a small number of patients managed by active surveillance, and again, results were encouraging. So what are the chemotherapy options? So it tends to be either a Hodgkin's approach with ABVD, or less commonly BCOP, or a NHL approach with CHOP or CVP. There's very little published data on CVP, particularly in the adult setting, and there's no randomized controlled trial to support the use of rituximab with chemotherapy in this setting. There is some data, however, from the Swedish population-based study, which showed little benefit from rituximab in the management of early stage. However, in the management of advanced stage, as shown in the graph here, the 5-year overall survival was 100% in those that had rituximab-containing regimens, as opposed to 78% in those that didn't, with 10-year survivals 100 versus 55%, thus supporting the incorporation of rituximab into chemotherapy regimens. So there are 2 different approaches, either a classical Hodgkin's or an NHL approach, and this tends to be centre-driven. ABVD has been shown in a paired outcome analysis with fairly long follow-up of 11.3 years that the 10-year overall survivals were similar between NLPHL and classical Hodgkin's lymphoma, around 75%. However, the 10-year time to progression, including transformation, was inferior for NLPHL at 63%, compared with 73%. In another study published in 2017, looking at progression-free survival depending on initial chemotherapy regime, the R-CHOP is in the red line, and other regimens, mainly ABVD, were in the blue dotted line, and you can see superior progression-free survival, which was significant for R-CHOP. So R-CHOP is thought to be more effective than ABVD and less toxic than BCOP. My approach to the management of advanced stage patients is consider active surveillance in low volume peripheral patients with no symptoms. If treatment is required, I usually offer RCVP. However, if I'm suspicious of high-grade transformation, then I give R-CHOP. If patients have serious comorbidities, then I give single agent rituximab. I'd just like to draw your attention to this publication last year, which was a consensus-based position paper from both paediatric and adult clinicians in the UK, trying to make a more uniform approach to all patients with all stages with NLPHL. I think the main question with NLPHL is, are we overtreating them? We know that the risk of dying of NLPHL is low, and this is just to remind you of the data that was shown in the previous pie chart, that only 23% of deaths are due to NLPHL. So we need to try and minimise treatment toxicity. And the global survey was published last year in lymphoma leukemia had shown that most patients receive ABVD or R-CHOP. I say this is obviously worldwide. I think in the UK that would not be the case. So how can we risk stratify patients to optimise management and minimise late effects? So part of the GLOW study was to develop a lymphocyte predominant prognostic score. 1 point was given for age 45 and above, hemoglobin less than 10.5 or 105, stage 3 to 4, and splenic involvement. An increased score identified those at highest risk of progression, transformation, and death, both lymphoma-specific and overall survival. And patients with a score of 3 to 4 had greater than 10% risk of lymphoma and NLPHL-specific death. So I think this might be the way forward, that we need to try and identify the patients that do require the more intensive treatment and minimise treatment for the others.
So thank you very much for listening.